we're excited to have Dr. Casper Nim join us. Casper is a chiropractor and a senior researcher at the Spine Center of Southern Denmark, as well as an assistant professor at the University of Southern Denmark. He earned his PhD in 2021 and has extensively studied spinal manipulation, including target sites, translation of pain sensitivity measures, and non-clinical aspects of spinal manipulation. He's been cited over 355 times in a very short amount of time, in 2021. That's excellent. Published several high-level reviews on spinal manipulation and the non-specific effects of spinal manipulation. And we're so happy that he's taken time out of his schedule to join us. The title of his talk today will be Overthinking Spinal Manipulation, Mechanisms, Techniques, Specificity, Education, What Really Matters. I would like to give a welcome to Casper, and you can enter your questions in the chat as we've done in the past webinars, and at the end we'll ask questions through the chat. Okay, Casper, take it away.
All right, thank you. Yes, I don't know what happened. I think my Zoom crashed, but let's see if it still works. All right, yes, you can see my screen.
You can.
That's perfect. Right. Well, thank you so much for the introduction and for inviting me and for everyone showing up. I really appreciate that. My overly long title of my talk has already been stated, so I won't do that again. But basically today we're going to talk about specificity of spinal manipulation. And now that we've done a bunch of different research, where do we go from here? And I guess I can kind of see in the crowd, I know some different people that most of you have probably, or if there's a student there, are probably currently being taught or educated that, specificity of spine manipulation, it really matters for outcomes. And I don't think you're alone with this. I was also taught this way. I think most of the manual therapy educations are taught that specificity is very important. But the question is really if specificity is important or if it's a thing of the past. So before we begin to understand this, we have to just take a quick dive into history because we have a tendency to be very interested in mechanisms of manual therapy. And it probably boils down to the history of manual therapy itself. So manual therapy has been around basically forever. You can find scriptures from the Egyptians. You can find paint wallings from cavemen touching each other in some kind of healing ritual. And, it was about 2,500 years ago by Hippocrates. He was the first to illustrate it using some kind of traction technique to cure spinal misalignments, or probably scoliosis, as it's called today. And then around the year 200, Galen was the first one to introduce some kind of manual therapy where you provide a ventral force into the spine. And this was to treat pain and improve function. And of course, he was the physician for the gladiators and one of the, forefathers of our understanding of pain. So it probably makes sense that he wanted these gladiators to work as well as humanly possible. And then for a long time, manual therapy kind of stood still. Like nothing really happened for almost 1,600 years, 1,700 years maybe. It was, this random guy on the corner of the street who did this alternative, therapy that had all kinds of different specifications. And we probably have to go all the way up until the late 19th century with Andrew Stills, who of course founded osteopathy, and D.D. Palmer, who founded chiropractic, who really put manual therapy onto the world map. And here I mean specifically, spinal manipulation, which is the, cracking therapies. And of course they did it they almost did the same thing. They found dysfunctions and then they treated them, but they did it in with very different ideologies or theories behind it, where, osteopathy was like Andrew Stills, he was an educated physician, he was a surgeon, he had this idea about physiology and how if the body was aligned, then, um, there was a better lymph flow and blood flow, and that could kind of cure the body from different diseases. Whereas Didi, the guy who invented chiropractic, he was a more, let's say, a spiritual guy. He was a traditional magnetic healer or an alternative practitioner, basically. And he had the same idea that if our body, and here he meant specifically if the spine was aligned, then, the innate system could also cure different diseases. But something interesting happened here. We're no longer talking about pain and function. We're talking about curing diseases and having the body heal itself. And so the mechanism, because that was the only real theoretical differences between these two guys. I mean, there's probably some differences in the way they treated people, but overall, they pretty much did the same thing, trying to treat the same thing, but with two very different ideologies. And it took some time now before we really got into the whole idea about pain where we are today. And when we are talking about manual therapy and the mechanism today, I think this model here by Olasky still to this day is my favorite model. I always use it when I teach students about what happens doing manual therapy, and it's simple, which is good because I like simple stuff. But it does depict the entire complex system, starting from zone one, which is the tissues, the context, the provider recipient, into zone two, which Carlos Giveros Montero, he published a review on a few years ago with a very beautiful graph here, also illustrating it a little bit different. So what happens inside the nervous system, and then basically you have the biomechanical effect and the neurophysiological effects, and that goes into zone three, suggesting that some kind of pain inhibition happens here, and that improves clinical outcomes. So one thing that all of this goes in is the tissues. And I always found this from a personal perspective. I found the tissues completely fascinating because when I was at university learning how to be a chiropractor, we were taught about these dysfunctions and how to find them. And a common approach that we were taught, and is also the most commonly used by at least chiropractors, I assume also physiotherapists and osteopaths today, is the idea that we can palpate some kind of dysfunctional segment. And these dysfunctional segments are important for improving patients. And they're not only important for improving clinical outcomes, in fact, they can be the indication of treatment itself. So if people, let's say patients, don't have these dysfunctions, they might not need or SMT at all or a manual therapy. And personally, I always found this completely fascinating because when I was a student, which was still now I think almost 9, 10, 11 years ago when I was taught this initially, I was palpating my fellow students, and honestly, I couldn't feel anything at all. And all of my instructors were saying, "Oh, it's normal. It will come. Just wait." And then when I came into clinic, I still couldn't feel anything. I talked to my co-students, like in clinical internships at university, I felt all kind of stuff, right? And I couldn't really feel anything at all. So I was perplexed what this dysfunction was that we learned so much about and how important it was. And I was in a lucky situation where I was allowed to actually do a PhD on this topic. So we just quickly designed a randomized trial where we basically took people with chronic low back pain, and then we randomized them into getting treatment at either their stiffest side in the back, on the low back, or the most tender side in the lower back, which are the two most common approaches that you would normally go for when trying to palpate these dysfunctions. And what was so interesting when we looked at our clinical outcomes was that despite the fact that we randomized between two different groups, they improved almost identically. It was as if they had received the exact same intervention. And we, of course, found this really interesting. And I can see there's a lot of researchers here, and maybe hopefully there's some pre-PhD students here trying to be researchers. I will say the next thing we did is not something I would recommend because we were so perplexed by this. And when we started this study, it was back in 2016, 15, 16, and a lot of papers were published on this, from 2015 and onwards. So with a couple of months to go before I had to hand in my thesis, we decided, say, hey, let's do a systematic review to actually look at this in a quantifiable way. Let's look at the literature and see if there's anything there. Is it really important where you target your manipulation? And we put our work pants on, as we say in Denmark, and we conducted this systematic review just in time for my thesis to be done. Where we basically found the same thing. We found 10 studies that had looked at this, and they all provided different treatments across different spines. So one of the studies looked at a clinical relevant site and a clinical irrelevant site, and one of them was within the same segment, 4 was within the same region, and 5 was across regions. And I just want to highlight one study in here, which was looking at the effect of spinal manipulated therapy for about, I think it's 150 people where they were included, and everyone was examined from the lower back where they had pain. And then one group was randomized into receiving manipulation at the exact clinical site of dysfunction. Like, this is where it hurts. This is where I feel the issue is. And then the other group was randomized to a completely generalized or generic manipulation at T3, 4, which is of course in the upper thoracic region. So there's a huge difference between these two approaches. And this was probably the best study that was in there, and it mimicked both our results, but also the results of the reviews, saying that there was absolutely no differences between these two groups, even at short-term follow-up and especially at long-term follow-up. So the biggest trial, was basically consistent with this. So after we were done this, we were all in the team a little bit confused, like, what exactly does this mean for teaching? What does it mean for our understanding of mechanisms and understanding of effects? And if you go back to the Bialowski model, do we need to focus less on tissues and maybe more on contextual effects? We were pretty much confused about what this really meant. And I would say, luckily, we were not the only people who were confused about it. So was the world of social media, where we, of course, shared our study, as anyone who had received public funding should. And I think one of the first responses we got was this guy, Philip Ebrel. He wrote an editorial. He basically wrote 3 pages about how much of idiots we were, uh, and how we didn't understand or could do research, which was interesting, to say the least. But it was not only Philip Ebrel. We shared the study publicly, and got a lot of negative feedback. Like, actually, really so much negative feedback that I had to take a break from social media for a few for a few days before I had before I could actually pick myself up and answer all the different comments or critiques that people had. And one of the critiques were that we included a very heterogeneous population, meaning that we included different regions within the spine. We're looking at both low back pain and neck back pain, and neck pain and low back pain, and so we were not able to do a meta-analysis. And I think this one was pretty easy to take care of. So I was part of conducting another review where we actually filtered a little bit more on what we wanted to include, and we were a little bit more stringent. And then we were able to do a meta-analysis, and we could show the exact same thing again. However, this time we could just say that there's a non-clinically relevant or statistical significant effect of providing targeted SMT of about, I don't know, what, 0.25 out of no, 0.2 points out of 10. So again, basically saying there's no differences between these two type of approaches, even when we do it more stringently like we did in this one. However, one thing we couldn't shake was that there were not that many studies that actually compared one type of SMT target to another type of SMT target. And we didn't really have an answer for this when we did our initial 2 reviews here. But as time went on, something magically, I almost want to call it, was brewing in the world of statistics. And that was especially in the early 2020s, and that was the rise of the network meta-analysis. And the network meta-analysis is basically, it's a normal meta-analysis on steroids. It allows you to do a more complex comparison where you can take studies with direct and indirect comparisons. And it's a powerful tool, but also one you have to be really critical of. And especially right now, network meta-analysis are all over the place. I think since maybe 2020, there has been more than 500 published within the health field. So it's something that is coming along really quickly now. And just for those who don't understand what a network meta-analysis, I'm going to go through it very quickly. And if by any chance there should be a biostatistician sitting out there watching this talk, I will say this is not 100% accurate of what actually happens. This is just a simplified example. So please bear over with me. But imagine that we had 2 studies, A and B. And study A uses or targets SMT to, let's call it option A. And study B uses another, or it targets another target in the spine. Let's call that target B. Then we have target A and target B here, and both of these studies are compared to placebo. Now, if we imagine that study A has an effect size of 1 and study B has an effect size of 0.5, then what the network meta-analysis allows us to do is to pool the placebo group, and then we can say the indirect effect of A over B is half a point, 1 minus 0.5. So that's the difference between A and B, which we can mathematically estimate. Now, of course, it gets a lot more complicated than this. Let's say we have 3 studies, A, B, and C, and A and B uses SMT procedure A and C uses SMT procedure B. Now we can begin to pool not only on the comparator, but begin to pool on the procedures of the SMT provided in these studies. And then again, it's the same trick. Now we have 2 different nodes of studies with pooled effects that we're comparing against a pool comparator effect. And again, we can look at the indirect effects. So this is the magic of the network meta-analysis, and also where you have to be careful, but we can talk about that in a little bit. So with this in mind, we conducted, I would say, the world's biggest systematic review on effects of spinal manipulation. We included 161 RCTs that compared high velocity, low amplitude SMT. So we're only talking about cracking manual therapy here. We didn't use, like, we excluded other types of like grade 1 through 4 mobilizations and only looked at high velocity, low amplitude stuff. So these trials compared SMT to obviously other types of SMTs, recommended therapies, non-recommended therapies, sham and placebo treatments, and then no treatments. And then what we did, we had about 190 SMT arms within this review, and we, 2 reviewers independently of each other, we classified them into one, how was the application target selected? So this is basically the same thing that we did the 2 prior reviews on. How was the thrust delivered, and in what region was the thrust delivered? And then we, again, for simplicity, we looked at pain and disability in both short and long-term follow-up. And short-term here means closest to the end of treatment, and long-term mean closest to 12 months follow-up. And the study included around 12,000 participants. So it's very difficult to summarize these results in a meaningful way, because you have to imagine that this network meta-analysis, or we actually did, as you can see, 3 different network meta-analyses. It corresponds to about 300 normal meta-analyses here, these 3 networks. So I'll make it very simple by saying, let's go through one procedure at a time, make sure you understand what it means, and then we'll compare the most clinically applicable one to the least clinically applicable one to say the differences between these 2 things. So the first one we did was the target procedure. And this is, we classified this as 2 things mainly. Was it a clinician who decided it, or was it completely generically decided? Which means that it could be by protocol. Let's say everyone get L5 treatment. And of course, clinician, it could be then based on palpation, that was the rationale, or it could be based on some other exam. There was some funny stuff going on there, like leg length discrepancy, x-rays, what have we. So if we try to compare a clinician selected site as indicated by palpation, which I think is being done, across the globe 100,000 of times each and every day. And if we compare that to a completely generic selection, so let's say, for instance, in the Brazil study by De Oliveira that I mentioned earlier, this would be the lumbar group receiving a very specific manipulation compared to the generic selection site at the thoracic spine. And here's the differences between these 2 things were not statistically significant, nor were they clinically relevant. In fact, they were estimated to be 3 out of 100 points. And that was actually favoring the generic selection. So there were absolutely no differences between choosing a relevant clinically selected site and a completely generic site. Now, the thrust procedure, we again categorized this whether this was either a specific thrust or a generalized thrust. And if it was a specific thrust, we looked at, was it done manually, meaning by hand, or was it done with some kind of instrument, like you can get those thrust guns and activators and different stuff. And again, if we try to compare these 2 things, we would say, okay, how about a manually delivered or hand delivered specific manipulation, which I guess is what, again, goes on in everyday clinic. And we compare that to just a generalized thrust. Just want to get movement into an entire region, for instance. That would be more of a generalized thrust. And again, here we found non-significant, both clinically and statistical results of, again, 3 out of 100 points, favoring a generalized thrust. For the region procedure, we again looked at whether this was done in the symptomatic region, in the non-symptomatic region, or across multiple regions. And this was obviously because we included both neck pain, low back pain. We even included thoracic pain, didn't find many studies. but we included all 3 regions, so we needed to make sure that we could encompass everything in our analyses. And again, if we compare the symptomatic region to the non-symptomatic region, the differences were again 1 out of 100 points, completely statistically relevant, and clinically as well. And again, favoring the non-symptomatic region. So what we ended up concluding mainly was that the effect of SNT does not appear at all to depend on the application procedures. In fact, it appeared to be completely redundant whether you did it in one way or in another way. And when we looked at disability more specifically, we actually found some statistical effects favoring a more generalized and non-specific approach to manipulation. And overall, we did the same thing for pain, but it wasn't statistically significant. But when we looked at the probability of providing the best SNT, it was almost in all of the analysis a generalized and non-specific approach that would win. So just to validate our findings a little bit, this was not the only thing we found. We also found that manipulations was just as good as other recommended therapies. It was a little bit better than non-recommended therapies. It was a little bit better than sham or placebo treatments, and it was moderately better than no treatment, which basically mimics, everything else that we have seen from reviews of manipulation, and will also echo all the other reviews that inherently will come over the next couple of years. However, we graded our results using something called the cinema, which is very equal to grade, which some of you may know. So it's a grading system of the certainty of the evidence, so to speak. And we concluded that this was low certainty evidence, which is why we don't try to argue that it's better to provide a non-specific manipulation, even though we found some effects of that. But because of this low certainty evidence, we downgraded our conclusion basically to say that it probably doesn't matter at all what you do. Now, there were 2 things that really made sure that we downgraded here. And one was that we did our risk of biases assessment properly, and we used Cochrane's risk of bias version 2, which is, when done sufficiently, it's very difficult to get other than a high risk of bias in these studies. Not to say that the studies are particularly good. There's a lot of bad studies out there that has really high risk of bias, but because we are looking at subjective outcomes, and it's almost impossible to blind participants, and it's completely impossible to blind providers, most of these studies will fall into the high risk category, which is also what we saw here, 84%, which means that all of our analysis were downgraded on this point. Another thing we saw was the inconsistency in the results. So sometimes there were differences between the indirect results and the direct results. So basically differences between RCTs comparing each other like you would do in a normal meta-analysis, and then the indirect results, meaning the mathematically estimated effects. Now, I would say that this was primarily when we compared SNT to other comparators. There was a lot of variability. I'll get to that in a second as well. When we looked at within SNT procedures, this was much less of a problem, but it still overall made sure that we were downgraded. I'm going to use the next 5-7 minutes here to tell you why our result still matters, because normally when you have low certainty evidence, the conclusion would be we need better trial, we need more evidence here. But we don't go there. We say that we don't actually need more evidence. I'm going to tell you why. First of all, exercise has the same issue, and they show the exact same thing. I mean, Jill Hagen has done a lot of work on this, and this was a network meta-analysis they did back in, I believe, 22 it was published. And although the title says that some types of exercise are more affected than others, these effect sizes are basically minimal. And they also conclude, like we do, that people who want to provide exercise can provide whatever exercise makes sense for the participant. Now, that's the same thing with exercise, but if you look just across the low back pain field here, we see the same pattern, that whatever intervention you provide to people, you will see an initial decrease, and then you just see variability over time. So we basically found the same thing here, initial decreases and then variability. So that was just the contextual thing about the effects of it itself. Now, the next thing I want to talk to you about is I like to call it the ritual of manipulation. I think that's a fun word for it. And if we try to look at this ritual, it really has 3 parts or 3 domains. So one is you have to find this dysfunction that we talked about earlier. Then you need to provide forces into that site, and then you need to change something within that site. That's the whole idea about the mechanisms and why manipulation works on people. So if you try to dissect this a little bit, then first of all, and there has been a lot of studies published on this, it's almost impossible to agree on where the dysfunctional site is, and that it doesn't really matter how you tend to look at it. Typically, clinicians can agree with themselves, but they can agree with each other. You also cannot use palpation to separate those with back pain and those without back pain. So there's not a whole lot of evidence. In fact, there's a lot of evidence saying that this is almost impossible to actually indicate what is a dysfunctional segment. And then the other thing that we published a paper on last year, just I just quickly want to highlight, is that static palpation is actually really difficult. Most clinicians probably have an idea that I can always find L4 and L5 just looking at the iliac crest. But in reality, when we look at this, it's really, really difficult. And we did a secondary analysis of a study that Greg Korchak led last year, where experienced clinicians palpated the same patient over 7 times in 12 weeks. And we found that already a few days after they did the first assessment, they were off by 1 vertebral segment on average. And actually, when we looked at it over time, the spine grew of these participants 2 centimeters, or approximately 1.3 inches or something like that, which was not because of morphological changes, I will tell you that, but it was simply because of error in palpation. So it's really difficult to say you want to provide treatment at this dysfunctional segment that you found once and then do it repeatedly, because you're not likely to actually palpate the same segment again. You're going to be 1 or 2 segments off on average. Now, let's say that you have found your, let's call it the random segment that you want to manipulate, then you need to provide forces into it. And we're looking a lot at these thrust parameters right now. And one thing that we do see is that it's highly varying, and it varies greatly. And even the contact point you have on the spine, it moves actually quite a bit on average, about 1 centimeter, whenever you actually deliver your thrust, which means that the thrust is not going to go exactly where you intended it to go. Another thing is that when you try to, sometimes in manual therapy, we have this idea that we want to induce motion. Let's say you want to induce lateral flexion, for instance. So you provide a vector to your manipulation. And actually, the only thing that happens here is that whatever forces doesn't go directly posterior to anteriorly, it is like dispersing into soft tissues and fascia, doesn't really go into the spine. And then, of course, this is especially for my chiropractic colleagues, when you try to do a really specific manipulation where you use your hand to provide the forces and you have a close thigh-to-thigh contact, it actually produces very little forces into the spine, and the chance of it saying pop, which everyone who provides manipulation wants it to say, it actually decreases compared to when you use a long liver thrust where you use a lot of force with your body and not use forces with your hand. It's actually much more likely that forces will go into the spine. And then lastly, independent of how you actually thrust, most of these forces will diverge into the disc where it will be absorbed. So now let's say that you have chosen your segment, you have attempted to provide your specific force into it, now you want to change it. And one thing we can look at here is the popping sound, or tribonucleation, or cavitation, or whatever theory you believe in there. And there's been quite a few studies on this that are quite nice, where they put on accelerometers and microphones on the lower back and even the thoracic back and also the neck. And then you can see, okay, what segment was targeted with the manipulation and what segment actually made the cracking sound. And one thing that was found here was that, first of all, these cracking sounds are heard throughout the spine, basically. I believe in one of the studies, it was about 15 centimeters away, or 10 inches away, which is obviously all the way up into the thoracic spine. But not only that, but if you want to make sure that you actually pop on the intended target, you've got to be pretty sure that you hear at least 2 or 3 pops, because in half the cases in the lumbar spine, it didn't pop at the intended target, which in this case was all 3. So yeah, you want to make sure that you hear a lot of popping sounds before you can actually say that you probably hit your target, which again just goes back to the forces being difficult to control because they happen throughout the spine. And I think this differentiates quite a bit from what we learn and what we're taught about manual therapy. And I think it pretty much boils down to that we have an erroneous idea about how the spine moves. So when we palpate, we have this idea that we can feel stiffness in different segments, but in reality, when we put forces onto the spine, it moves as a continuum, basically 3-point bending. And in this study here, you can see the kilos on top here. And in fact, you have to add on the instrument, which is about 2 kilos itself. So we're basically adding 8 kilos of pressure here using a very small wheel into the spine. And 8 kilos of, well, not pressure, but 8 kilos of force here is much more than you would do with your palpation. It's probably also more than most of you would do with your manipulation. And it moved the spine itself millimeters. It was basically just soft tissues being, squished together. So the fact that it's very difficult to move the spine, and also that the spine doesn't move intervertebrally, but it moves as a continuum, it really goes to say that why we probably saw some of these results, and why it's mechanistically so difficult. So then, of course, the question is coming up, like, what are we doing in clinical practice? Are we just entertaining patient while time goes? Does it matter even how we treat people? Is it all non-specific effects? And if we go back to our model here, right, we can say now that, okay, the tissue in the patient is probably not what drives the effects. Maybe there's something in the mechanical stimulus. We're not quite sure about that yet. We haven't really tested it out, but it probably doesn't matter that much. That means we do actually have to look more at context. And if we talk about these non-specific effects, 2 major reviews were published, one last year and one the year before that. One was looking specifically at low back pain, the other one was looking more broadly at physical and psychological interventions. But luckily they found the same thing, so it's easy to just disseminate both of them simultaneously. Because what they did was included studies that had 3 arms, so an intervention arm, a sham arm, and a no treatment arm. And they found, not surprisingly, and exactly what we found as well, the interventions had a small effect over sham, had a medium effect over no treatment, and even that sham actually had a small effect over no treatment, which of course shouldn't happen, but that's the placebo effect. And now this means that we can actually dissect how much is the contextual effect. But it actually gets a little bit more complicated than that, because when you look at these different shams, there was actually a small to moderate effect size of using a manual contact sham compared to other types of sham. Again, saying that, we touch people and it helps them. Like it's probably a good thing to touch people. At least it has more placebo effect than not touching people. And what they end up concluding, basically both of these studies, is that around 50% of what we see of improvements are basically just changes that are observed with no treatment. It's contextual effects, regression towards the mean, or whatever you want to call them. And about 1/3 is your specific treatment effects. And then the rest is just placebo. Now that means when you go to clinic tomorrow and a patient comes in 8 out of 10 on a typical VAS scale, you treat them and they say, oh my God, I feel much better now. It's about 2 out of 10. 3 of those points are going to be explained by contextual effects. 1 of the points are going to be explained by placebo because you provided the interventions that they expected, for instance. And 2 of the points that are left is due to your specific intervention that you provided. Now, this is really important to understand because just from a probability from purely statistics, if you only have 2 points out of 8, for instance, if you only had 1/3 of the total effect to actually look at, there's very little statistical probability that, independent of how you actually do that treatment, will matter greatly on the outcomes. It's just a question about statistics and probability and simple math here. So that's probably also why we see the results of what we do. It's simply not really possible to provide more effects than what we saw here. So in the end, we end up concluding that, the mechanism of manipulation is likely a widespread, and that's important to realize here, a widespread mixture of biomechanical, neurophysiological, and contextual effects and the interaction between them. And we don't really understand that completely yet. I think that's some of the ideas that Forsnet really wants to do and is helping do. But one thing that is clearly not happening here is that we're looking at a segment-specific effect here. It's more likely, if you want to go down to at least the bare minimum, it's a regional effect that we see when we provide spinal manipulation. So what exactly does this mean for education? We have some recommendations here, mostly that, education programs are pressed on time and the students are always being overworked, at least in most cases, at least at my university, they are being overworked. And in some curriculars, at least in chiropractic, like up to 25, 30, sometimes 40% of the curricula is used on manual therapy treatment or training. And we could probably limit that a little bit and input other more important stuff. Because what we really want to teach people, and that's providers, is that you have to provide safe and comfortable manipulation for both the patient and for yourself. Because we also know that injuries in providers of manual therapy is quite high because it's quite tasking for the joints and everything else. So you shouldn't worry too much about specificity. Just find whatever works for you. And I think most experienced clinician actually does this. And then I think the jury is still out on these force time characteristics, whether it's actually important to be able to have the capacity to actually modulate them. I think it is, at least for safety or comfortability. Like some patients need more forces, some patients need less forces. And then I think we have a huge gap here that we need to learn and understand and enhance these contextual effects and understand that it's not a placebo effect. It's not cheating people necessarily. It's something that happens due to your setting, the way you communicate, all of these different stuff. And that's highly important. It's actually the main driver of our effects. And it appears that touching someone actually has a greater placebo effect, at least. And we need to learn how to enhance this. And for research, just briefly, I mean, and this has also been in some of the studies that we have looked at on the priority setting, we need to understand these contextual effects better. We simply need to understand how they modulate and interact with these other mechanisms that we typically have looked at. And then I would say I don't think we need more studies comparing SMT to exercise, for instance, or other small studies comparing one type of treatment to a simple intervention to another type of simple intervention. Because in most cases, the results are either going to leave one way or the other way in a very small effect size, or it's going to be the same, right? We've shown this now like in so many different studies. It's probably not that important anymore. But one thing is still left unexplained here, and that is the variability in the effect sizes that we see in manipulation. And we were unable to, provide these more specifically in our study, even though we tried. But now we're sitting on this huge database, and this is probably more a call to researchers. We're sitting on a database now of 244 trials where outcomes have been extracted, risk of bias has been done, all of that. We have so much data there. And these are the results here when we just plot the mean differences for pain outcomes in the short term, right? We see huge variation. Some studies find that SMT is just the best thing in the world. Other studies find that it's probably not worth anything at all. So there's still a lot of variability in what we're doing. So lastly, I just want to acknowledge everyone who worked with me on this. This was a huge interdisciplinary and international team effort. And lastly, I just want to highlight my old PhD supervisor, Greg Korchak, who I have a hard time imagining he's here. He has really been a supportive person throughout my career. And Martha von der Bosch and I were lucky enough to visit him here in February in his home in Edmonton. So yes, thank you very much.
All right, excellent. Okay, and just a reminder, if you have a question for Casper, go ahead and put it in the chat. I'll begin with one question that I had, because in a cat study that we did, looking at a feline study, we were able to manipulate two segments away and get almost 80% of the neurological response of adjusting we adjusted L4 and L6, and L4 manipulation received about 80% of the muscle spindle output as the L6, using recording from the L6 nerve root. And so you have this regional, as you mentioned, a regional effect on there. And I think biomechanically, we don't see a whole lot of movement in the spine, but neurologically, each dorsal root goes to 3 levels, right? So if you're affecting, let's say you affect an L3 manipulations affecting 3 levels in both directions, with there, you're affecting the whole lumbar spinal cord or dorsal root connections with there in the spinal cord. So what do you think? I mean, as far as I know, we think, and that to me, it makes sense. It doesn't explain, if you're a segment off, it doesn't matter for the outcomes, because you're really actually getting the same effect neurologically. We just don't measure that very often. It's very hard, it's invasive with that. But that would explain why specificity doesn't matter in my mind. If you're getting 80% or plus of the same response, if you're 2 segments away from where you think that this function's at. But what are your thoughts, I mean, as far as neurologically, what needs to be done if that's was the case versus biomechanically?
Yeah, I think it's a lovely study. I read it a few times trying to understand it. I completely agree, and I think, but I actually want to go back a step further, because what you've shown it in is these animal models where you typically provide some kind of very specific thrusts driven to a single site, right? That, I mean, that is almost impossible to do in humans that are, breathing and awake and with more complex spines, or maybe not more complex spines. I don't know about that, but at least, in movement, etc., whatever they do, breathing patterns and all that. So I do think I do one agree with you that neurophysiologically that's probably what we see, and again biomechanically it's probably the same thing, and I think it's even more enhanced in humans than it is in, let's say, cats or pigs or sheep or whatever specimen you want to look at.
Okay, thank you. Yeah, I've always imagined like you're lighting up the whole lumbar spinal cord when you give a lumbar manipulation, and not just a segment. You're getting this huge response neurophysiologically with that we just don't see. A couple of other questions that we've got in the chat. Can you discuss phenotyping, the pathology of pain dysfunction? Are we at the point where we can effectively place each patient on a spectrum, for example, between biomechanical, inflammatory, and psychosocial dysfunction to optimize treatment?
I wish we could. Uh, I don't exactly think we're there yet. And I think but that's the goal, right? That should probably be the goal. How can we, how do we have that phenotyping, and then how can we adjust our manipulation to actually affect these different phenotypes? And I think the way that we communicate is important, and force distribution and forces in itself is probably important. So the strategies that the provider uses, I think that's tremendously important, but I'm not aware of anything that has actually any hard evidence that we can do this. And even in fields that are way far beyond ours, like exercise, for instance, there's a lot more knowledge there. They also have the same issues. So I don't think I think that should be the goal, definitely, and I do think that's one of the ForceNet goals as well. But getting there is going to be very, very difficult. We're starting a study in Denmark, Martha Funabashi and I, in about a few months, where we will attempt to look at this to see, measuring more broadly both neurophysiological, mechanical, but also psychological changes, both over time, but also specifically at baseline, trying to understand if we actually can predict something here. But let's see.
Okay, excellent.
Let's see if we can recruit first. That's my main concern right now.
It's always a concern with that. Okay, and the next question here we got is in the stereo environment of the RCT environment of blinding seems to make changing context contextual effects difficult. Has there been any studies looking at clinical messaging context or clinical messaging context alongside a consistent procedural SMT to take a look at the difference in outcomes? So basically, I guess the sterile environment of you controlling everything in the RCT with there has there been any studies looking at the messaging and context alongside with a consistent delivery of SMT for different outcomes?
um, yeah, this is a little bit outside my field. I could imagine in psychology there's a lot of this. Within the world of SMT, I cannot recall that I've seen anything that specifically. A lot of people have looked at expectations, and some have used like these enhanced, like, trying to enhance people's expectations, but specifically trying to modulate the contextual effects. I know right now at the at the Canadian Chiropractic Memorial College, they're trying to do something like this, where they can actually, because of these force sensing tables, they can standardize the forces being delivered, um, at least to a certain degree, where they then want to modulate what is actually being told and what is not being told. But I'm unfamiliar with anything that has been conducted now. But in psychology, I think it's one of the things that speaks out, like showing empathy, for instance, has in some cases huge effect sizes. And if that's, of course, we can go down the road of psychology interventions, which are highly difficult to reproduce.
Right, with that. Okay, with there, we've got, you mentioned that the popping sound comes from various parts of the spine, and I've read a couple studies specifically referencing the facet joints. Besides the facet joints, are there any other specific areas where the popping sounds arise?
I don't know. I mean, most of what we know about joint popping comes from the finger joint, like pulling your finger and then looking in some kind of imaging and measuring the sound, what actually happens. That's not a facet joint. That's a completely different type of joint. There has been something done about with ultrasound where you can see the formation of bubbles. That doesn't answer specifically what structures the sound come from. But I would say you know, theoretically it makes sense that it's separation of the joint the joint plates or the facets. I think that makes a lot of sense. But could ligaments and everything else make the same kind of popping sound up? I mean, why not?
Wouldn't you have to have a synovial fluid though? I thought it was the nitrogen gas in the synovial fluid that actually builds up. And so if you don't have the synovial fluid, like the disc, for instance, wouldn't have synovial fluid with that, or the ligaments perhaps. But it's interesting with that. But that's why the
Yeah,
facet, you
yeah,
know,
and I want to clarify that. What I mean is when you look at it that specifically, yes, obviously you need some kind of fluid to make these bubbles, but from a clinical standpoint, I think you can hear other factors making those noises, right?
yes, yes, excellent. Okay, a couple more questions with their, everyone has commented on how great a talk it was, so that's great. With there, we appreciate it. With there, basically two questions. What do you think are the most important contextual factors that need to be studied with there, and how do we effectively teach entry-level clinicians to emphasize or prioritize these factors in their practice?
I think empathy is one of them, and being a good listener. I think we could learn a lot from the new trials that are coming out now on cognitive functional therapy, for instance. I think what they do, even though it's just another one of these paradigms, maybe, but I do contextually think it makes a lot of sense to actually listen to people, share their stories, and then use their stories into exposing them to different things. And there's no reason why we cannot do the same in manual therapy, listening and being understanding, and then hopefully maybe at least attempting to. Some people would need a more mechanistic explanation. Some people probably do not need a mechanistic explanation because that would only involve fear and you know and catastrophizing thoughts. But again, we're not at a point at all where we can begin to understand or predict or even explain some of these. But I do think we could learn a lot from the CFT guys, and then I would say empathy is just important in the field of psychology. So I couldn't see why it's not important here.
Excellent. Okay, with there, we got one more question here. With there, as philosophical views have changed over time, do you have recommendations for approaching a conversation with patients who have been told or hold beliefs regarding specific anatomical changes within the spinal manipulation in a way that does not sacrifice allegiance or lead to nocebo treatment effects? So,
So I think this is a good point where we're sometimes misunderstood when we present our results here, because we're not saying that providing a specific manipulation is worse than not doing it. So if the patient comes in and has that belief, then I mean, basically play along, right? That's that's really not doing any harm. Probably trying to get into an argument about specifics and studies and meta level research and all that is probably not helping anyone. So yeah, and that's also why we try to say like experienced clinicians today, go ahead and do whatever you want to do. Like I have no concerns about that as long as we don't impact on safety of the manipulation. Then you can go ahead and do what you want. But this is important for younger clinicians who might be struggling with confidence levels, just like myself, I was, and especially for education, because we can spend our time more wisely if we update our view on how this actually works or likely works.
okay, excellent. With there, and Stephen Pearl commented that on the finger, in the fluid there, synovial fluid, 80% was CO2. I think I mentioned nitrogen with there, so I may have got my gases incorrect with there. I do remember that paper. It's been a long time, but he gave this citation, 1971, with there. So yeah, it's been a while with that on what the gases built up were, but it's always been interesting whether you need that or not. One last question that I have is threshold. Do you think that there is outside the contextual factors, if we stick with just the physiology, do you think is there a threshold, a physiological threshold that you have to reach on there with the amount of force you apply to elicit a specific physiological effect? So therefore, I mean, we have different instruments, let's say, whether it's activator or even low forces, manually applied low forces. But do you think there exists a threshold where if you fall below that threshold of force on that, no matter where it goes in the tissue, but you need a certain amount of force to reach a certain tissue in order to have an effect? Do you think that's a reality or fiction?
Um, that's a super good question. Just before I get to it, I just want to highlight Stephen Purley, who came in the chat. Always good with a citation. I usually, whenever I do sort of like these type of talks, I always talk about this anecdote about Stephen Pearl actually sending me a very nice email after I completed my my initial RCT study, where he said, and I quote him, I would have predicted your results 10 out of 10 times, and then he provided basically, I don't know, 2, 3 pages of why. And that was actually what drove my entire, like, what actually drove my research career down this path. So I'm hugely grateful for Stephen Pearl. I love when he comes in. So thank you, Stephen. Now to answer your to answer your question, um, from a physiological standpoint, well, we do see changes in whatever they have measured using different forces, right? So we know that something happens. If there's a magical lower limit, I could imagine, but on the other hand, I don't think that lower limit is as important as if the patient is uncomfortable or would prefer something very low level. I think that's probably more important than the whatever physiological effect is in there. And it goes down back to my, 1/3 of what we're explaining with our interventions. So I professionally, academically, yes, I do think we need to provide a certain amount of force, and that is going to differ, obviously, for different uh, nervous systems. Um, but I don't think it matters a whole lot as long as you provide whatever is needed for that individual, right? Like if some patient really, really wanted a half thrust, and you go way beyond the whatever physiological barrier or limit we're talking about here, or baseline, even if you hit plus 400-500%, but the patient was expecting 1,000% more, it likely won't matter a whole lot for how they actually feel.
Excellent, excellent. That's good thoughts with that. Okay, well, listen, we'll go ahead and wind up. We want to thank you for taking your time. Excellent talk, excellent discussion with there, and food for thought with that for any manual therapy practitioner with that in any capacity and other as well. So, Casper, we thank you. Look forward to seeing your next work that soon to come, I'm sure, and the results that you find. And thank you for joining us today.
Well, thank you very much, all.
All right. Goodbye, everybody.